In this clinic series, we're taking a deep dive into coronary artery disease. Hi, I'm Dr. Song. I'm an internal medicine physician who also started her own clinic called HealthNet Clinic. Let's start with coronary artery disease. Coronary artery disease refers to a disease where there is narrowing of the coronary arteries due to atherosclerosis or plaque buildup. It can lead to myocardial infarction or heart attack. Plaques are formed by lipid deposition and inflammation, a gradual process called atherosclerosis. Atherosclerosis affects the aorta and the medium to large arteries. It begins in the second decade and is accelerated by high blood pressure, high cholesterol, high blood sugar, and smoking. The pathophysiology of atherosclerosis is that it develops when low density lipoprotein or LDL accumulate in the arterial wall and are engulfed by immune cells called macrophages. Platelets adhere to the arterial wall and promote accumulation of debris. The resulting atheroma can lead to narrowing of the coronary arteries that restrict blood flow. HDL, or high-density lipoproteins, help decrease atherosclerosis by extracting lipids back into the bloodstream. Chronic stable angina refers to the recurrent chest pain or shortness of breath that results when there is restricted blood flow and oxygen delivery to the heart muscle. Men typically develop symptoms between the ages of 55 and 65, and women present a decade later. The distribution of the blood supply affects its presentation. In the left heart, coronary artery perfusion only occurs during diastole or heart muscle relaxation. In the right heart, the myocardium is perfused throughout the cardiac cycle. Oxygen is extracted at a high rate, which is a unique feature of myocardial tissue. This means that there is little capacity to increase myocardial oxygen extraction during periods of increased oxygen demand. Therefore, increased oxygenation can only be achieved through increased coronary perfusion. Coronary autoregulation maintains myocardial blood flow when coronary perfusion pressure decreases. With significant atherosclerosis, greater than 90% stenosis or narrowing, coronary arteries are maximally dilated and blood flow cannot be further increased. Thus, severe stenosis results in ischemia or lack of blood flow with just minimal exertion. With coronary collateral circulation or the development of additional blood vessels, a slowly growing stable plaque allows for coronary collateral circulation to bypass the plaque. In contrast, an unstable atherosclerotic plaque does not allow the development of collateral vessels because it is more likely to rupture. With myocardial oxygen supply-demand mismatch, the myocardium is unable to get enough oxygen, which drives myocardial ischemia and causes symptoms of stable angina or chest pain. The supply is limited from decreased coronary artery blood flow. The demand is increased from increased heart rate and contractility, afterload, or cardiac muscle mass. Other than obstructive coronary artery disease, other causes of stable angina or chest pain results from coronary microvascular dysfunction, severe aortic stenosis, or severe aortic regurgitation. The presentation of stable angina include gradual onset of substernal or central chest pain associated with shortness of breath, nausea, diaphoresis or sweating, or pain radiating to the shoulders, neck, lower jaw, or epigastrium or mid-abdomen. The pain is reliably provoked by exertion and relieved by rest or nitroglycerin, not reproducible by pushing or palpation of the chest, and lasts 2 to 10 minutes. Some patients experience an anginal equivalent where they only experience nausea or dyspnea or shortness of breath without chest pain that's relieved by rest. The diagnosis is based on clinical presentation, and testing is based on the estimate of pretest probability of obstructive coronary artery disease. Patients less than 40 years old have less than a 5% chance of chest pain being related to obstructive coronary artery disease, and diagnostic testing should be avoided due to the risk of false positive results. Women 40 to 59 years old have a 5 to 15% pre-test probability, and testing is sometimes considered. Men older than 40 and women older than 60 have a greater than 15% pretest probability, and diagnostic testing with stress imaging or CT angiography is recommended. The types of cardiac stress testing include ECG or electrocardiogram stress testing using a treadmill to exercise. Myocardial ischemia is detected with ST depressions on ECG during exercise. ECG stress testing is non-invasive, low cost, and recommended in patients with a low pretest likelihood of obstructive CAD. Echocardiography stress testing uses exercise or a pharmacologic agent. Myocardial ischemia is detected by visualizing localized systolic wall motion abnormalities. Nuclear stress testing uses exercise or a pharmacological vasodilator to simulate vasodilation. CT coronary angiography is non-invasive and uses CT scanning with intravenous contrast. Coronary calcium scoring uses CT scanning to quantify the amount of calcium, which correlates with atherosclerosis and is used as a screening tool for asymptomatic patients with medium high risk and as a diagnostic tool for symptomatic patients with low risk. Invasive coronary angiography is the gold standard and requires left heart catheterization or using a catheter to directly access the coronary arteries and injecting a dye into the arteries to visualize atherosclerotic narrowing. A stent can be placed. The goal of testing is to confirm or exclude obstructive coronary artery disease and to determine if patients need coronary revascularization. Patients with normal stress testing have a low likelihood of clinically significant coronary artery disease, and no further testing is indicated. Patients with abnormal stress testing likely have obstructive CAD, and medical treatment is warranted. A positive ECG stress test should be followed by stress imaging or CT coronary angiography. In some cases, CT coronary angiography showing normal coronary arteries may warrant further evaluation for vasospastic angina or microvascular dysfunction, which are two other conditions that can cause chest pain. Other likely diagnoses for acute chest pain include myocardial infarction or heart attack. It differs from stable angina in that it results from atherosclerotic plaque rupture with overlying thrombus and sustained occlusion of coronary blood flow. It presents with persistent pressure-like chest pain that does not resolve with rest and requires emergency treatment. Vasospastic angina results from hyperactivity of coronary smooth muscle and presents with recurrent chest pain. It can be confirmed with acetylcholine testing during invasive coronary angiography. GERD or gastroesophageal reflux disease can present with substernal chest pain similar to stable angina. It often occurs shortly after eating and is worsened in a reclined position. Managing coronary artery disease includes both lifestyle modifications and medical therapy. Complete smoking cessation provides the greatest risk reduction. Treatment of conditions that worsen myocardial oxygen demand supply mismatch, like hypertension or anemia, is indicated. Beta blockers like metoprolol or atenolol are first line. They reduce myocardial oxygen demand by reducing heart rate and contractility. Non-dihydropyridine calcium channel blockers like diltiazem and verapamil are alternatives and also reduce heart rate contractility. Additional therapy like dihydropyridine calcium channel blockers can be added when needed. Nitrates like short-acting sublingual nitroglycerin are used as an abortive agent when anginal symptoms occur, or longer-acting nitrates such as isosorbide mononitrate or isosorbide dinitrate are added as prevention. Ranolazine is designated for patients with stable angina refractory to other medications. Coronary revascularization via stent placement or coronary artery bypass graft surgery is indicated for lifestyle-limiting angina symptoms refractory to maximum tolerated medical therapy. In patients who are asymptomatic with severe left main artery disease or multivessel disease, revascularization is indicated to improve cardiovascular survival. Complications of coronary artery disease include ischemic heart disease manifesting as heart failure and coronary steal syndrome. The prognosis of coronary artery disease depends on the extent of the underlying obstruction. Patients with left main artery disease or three vessel disease have a worse prognosis than patients with one vessel disease. Stable angina can be relatively benign, whereas MI without preceding angina has a worse prognosis. Let's talk about acute coronary syndrome, which is a common and often feared complication of coronary artery disease. Acute coronary syndrome is a condition of lack of blood flow and death of heart muscle. It results from rupture of a plaque in the coronary artery, leading to blockage of blood flow that supplies the heart muscle. If myocardial ischemia persists for a prolonged period greater than 30 minutes, irreversible cell injury develops and eventually leads to tissue death or infarction. There are two major subtypes of myocardial infarction. The first one is STEMI, or ST segment elevation myocardial infarction, and the second subtype is NSTEMI, or non-ST segment elevation myocardial infarction. These are named based on the patterns found on ECG, or electrocardiogram, which are tracings of the electrical activity of the heart. For pathophysiology, a STEMI is caused by acute or sudden rupture of an atherosclerotic plaque. The thrombus or clot is extensive enough to fully occlude the coronary artery, completely blocking blood flow. The injury to the myocardium is full thickness and creates a characteristic ST segment elevation. The ST segment elevation is the primary diagnostic feature of a STEMI. For NSTEMI, the atherosclerotic plaque rupture is partially occlusive and leads to partial thickness infarction. NSTEMI has nonspecific changes on electrocardiogram, including ST segment depressions and T-wave inversions. There are two subtypes of NSTEMI. Type 1 is due to atherosclerotic plaque rupture. Type 2 is due to oxygen supply-demand mismatch. For example, in a patient with underlying coronary artery disease who then develops an acute illness like sepsis, which leads to elevation of troponins, which is a biomarker of myocardial muscle injury. For unstable angina, these cases have now been reclassified as NSTEMI due to the increased usage of high sensitivity troponins. For localization of myocardial infarction, the left anterior descending artery, or LAD, supplies the left ventricular anterior wall, septum, and cardiac apex. The left circumflex artery, or LCX, supplies the left ventricular lateral wall and sometimes the inferior wall in left dominant circulation. The right coronary artery supplies the right ventricle as well as the left ventricle inferior wall in right dominant circulation. Approximately 5% of people have codominant circulation. Obstruction of the LAD is also called the widowmaker because it causes anteroseptal, anterolateral, and apical MI. Obstruction of the left circumflex artery causes lateral MI or sometimes inferior MI. The pathology of MI is that tissue without timely reperfusion develop collagenous scarring. The clinical presentation includes acute onset of pressure-like chest pain in the center of the chest that often radiates to the left neck or the shoulder. The pain is persistent and not relieved with rest, which differentiates acute coronary syndrome from stable coronary artery disease. Patients may also present with dyspnea or shortness of breath, diaphoresis, fatigue, anxiety, nausea, vomiting, or epigastric pain. Women and elderly are more likely to have gastrointestinal symptoms in the absence of chest pain. Patients with advanced diabetes may have silent MI or MI in the absence of chest pain and other symptoms. In patients who develop acute heart failure, they present with respiratory distress, hypotension or a drop in blood pressure, syncope or fainting, and sudden cardiac arrest. On physical exam, patients may have extra heart sounds, S3 and S4, fever, tachypnea or rapid breathing, or lung crackles. The diagnosis of NSTEMI is made when there is new ST segment elevation at the J point, or where the QRS meets the ST segment in 2 or more contiguous leads. It can also be diagnosed when there is a new left bundle branch block, isolated ST segment elevation in AVR or V1, accompanied by widespread ST segment depression in the lateral or inferior leads, suggestive of LAD occlusion. ST segment depression in V1 to V3, suggesting occlusion of the artery supplying the inferolateral or posterior wall, or ST segment elevation in V4R to V6R, suggesting right ventricular infarction. The diagnosis of NSTEMI is made with clinical presentation of persistent chest pain and serum troponin elevation. An ultrasound of the heart or echocardiogram may help confirm the diagnosis of NSTEMI, but is not required to diagnose STEMI. The management of acute coronary syndrome is immediate hospital treatment with emergency coronary reperfusion within 90 minutes of first medical contact for a STEMI, or for an NSTEMI, coronary angiography within 24 to 48 hours. Medications reduce myocardial demand and inhibit thrombus formation. They include dual antiplatelet therapy, nitrates, beta blockers, anticoagulation, and statins. In patients with right ventricular MI, nitrates, diuretics, and opioids are avoided because they worsen hypotension, and intravenous fluids are given instead. Coronary artery bypass graft surgery is indicated when there's still need for revascularization after PCI or percutaneous coronary intervention, such as in patients with diabetes with 2-vessel disease involving the LAD, 3-vessel disease, or left main artery disease. After initial treatment, therapy is focused on preventing another MI. Lifestyle modifications include exercise, diet like Mediterranean diet, and complete smoking cessation. Pharmacological therapy includes dual antiplatelet therapy, continued for 1 year, beta blockers continued indefinitely, high-intensity statins continued indefinitely, ACE inhibitors or ARBs, and spironolactone. Complications of MI include ventricular arrhythmia, which is the most common cause of death, atrioventricular block or bradyarrhythmia, or mechanical complications such as interventricular septum rupture, left ventricular free wall rupture, left ventricular aneurysm, and papillary muscle rupture. The prognosis of MI has improved substantially with reperfusion therapy. The 30-day mortality rate of STEMI is about 10% or less, and for NSTEMI is about 2%. Right ventricular MI has high acute mortality, but low mortality for those who survive. Acute coronary syndrome requires prompt intervention in order to limit myocardial tissue death and to reduce morbidity and mortality. Let's talk about vasospastic angina. Vasospastic angina, formerly known as variant or princemetal angina, is characterized by intermittent coronary vasospasm that leads to transient chest pain. It is usually found in patients that are 50 years or younger who do not have cardiovascular risk factors. Recognizing it is important to prevent complications and to reduce symptoms. The pathophysiology of vasospastic angina is due to the hyperreactivity of the coronary arterial wall to acetylcholine, which leads to intermittent narrowing of the coronary arteries. Risk factors include smoking and cocaine use. Migraines and Raynaud phenomenon are also associated. Presentation is with recurrent episodes of chest pain lasting 15 minutes or less, accompanied by dyspnea or shortness of breath, diaphoresis, palpitations, or nausea. They may occur during rest or sleep and may also be induced by hyperventilation, stress, or exercise. They improve characteristically with nitrates. ECG findings demonstrate ST segment elevation in contiguous leads, and high sensitivity troponins may be elevated. The diagnosis is based on clinical presentation and confirmed with ambulatory ECG monitoring or an event monitor. Cardiac stress testing or coronary Angiography shows no evidence of obstructive coronary artery disease. Management is with smoking cessation and sublingual nitroglycerin as needed, as well as calcium channel blockers, statins, and isosorbide mononitrate for persistent symptoms. Medications that cause vasospasm and should be avoided include beta blockers without alpha blocking properties, triptans, and cholinergic agents. Complications include MI, cardiac arrhythmia, or cardiac arrest. The prognosis is usually favorable, but up to 25% of patients experience complications without treatment. Let's talk about complications of cardiac catheterization and coronary interventions. Cardiac catheterization refers to the instrumentation of the heart's chambers via the blood vessels, arteries, and veins. Left heart catheterization is commonly used to access the coronary arteries for invasive coronary angiography, which involves injecting dye into the coronary arteries to allow for visualization of atherosclerotic narrowing and for placement of stents. Complications of left heart catheterization and invasive coronary angiography include local vascular complications at the access site, the coronary arteries, and the aorta. A hematoma develops when there is a full thickness tear in the arterial wall and blood seeps into the surrounding tissues. The presentation is a firm and tender non-pulsatile mass. Management is conservative and is with compression and pain medications, but larger hematomas may require surgical draining. A retroperitoneal hematoma is a serious complication of femoral arterial access and may be relatively pain-free or present with flank pain or back pain. Treatment should be done immediately with fluid resuscitation, blood transfusion, reversal of anticoagulation or antiplatelet therapy, and surgical consultation. A pseudoaneurysm is similar to hematoma, but bleeding is confined to the arterial wall. Clinical presentation is a pulsatile mass. Diagnosis is with ultrasound. Management is with ultrasound-guided compression, but larger pseudoaneurysms may require endovascular or surgical repair. Arteriovenous fistula occurs when both artery and vein are punctured. Clinical presentation is a mass with a palpable thrill and bruit. Diagnosis is with ultrasound. Management is with ultrasound-guided compression, or for larger arteriovenous fistulas, surgical repair may be necessary. Other complications may include vasospasm of the radial artery, post-procedural artery occlusion, or compartment syndrome of the wrist or hand. Stroke is rare and occurs in 0.4% of patients and is caused by atheroembolism, air embolism, or intracranial hemorrhage. MI is rare and is caused by coronary artery dissection, coronary side branch occlusion, or embolization. Acute kidney injury occurs in up to 15% of patients within 48 hours of undergoing left heart catheterization. It most commonly occurs in the elderly and in patients with chronic kidney disease, heart failure, or diabetes. Cholesterol embolization syndrome occurs when atherosclerotic plaque breaks off, often from an abdominal aortic aneurysm. You may experience confusion, livedo reticularis, or lacy blue rash, or blue toe syndrome. Pseudoallergic reaction to iodinated contrast is uncommon and may present with flushing, hives, wheezing, or hypotension. Death occurs in less than 0.1% of patients undergoing left heart catheterization for diagnostic purposes and in less than 1% of patients undergoing interventional therapies. Let's talk about peripheral arterial disease. Peripheral arterial disease, or PAD, results from atherosclerosis of the peripheral arteries. The pathophysiology of peripheral arterial disease mimics that of coronary artery disease. Atherosclerosis deposits lipids and causes inflammation in the arterial walls, which leads to narrowing and eventual restriction of blood flow to the extremities. The presentation includes claudication, which is the equivalent of stable angina. It is cramping pain provoked with walking and relieved with rest. It commonly occurs in the feet or calves due to involvement of the popliteal and tibial arteries, but may occur in the bilateral hips, thighs, and buttocks. Ischemic rest pain is advanced peripheral artery disease where symptoms occur at rest. Acute limb ischemia is a medical emergency and is the equivalent of a myocardial infarction. Risk factors for PAD are the same as CAD and include age, smoking, hypertension, high cholesterol, diabetes, and family history of atherosclerosis. The presentation of PAD varies with severity and acuity of ischemia and is separated into three syndromes. Many patients remain asymptomatic because they limit activity to below the threshold where claudication symptoms occur. For chronic symptomatic PAD, patients present with cramping in the foot or calf that occurs with walking and is relieved with rest. Cool, dry, shiny, hairless skin on the legs, diminished pulses in the lower extremities, and thick, brittle nails. For chronic limb-threatening ischemia, patients present with severe cramping of the forefoot or toes at rest, which worsen with elevation and is improved with hanging the toes off the side of the bed. They may also have ischemic ulcers on the lateral ankle or distal toes and dark-colored gangrenous tissue. For acute limb ischemia, patients present with abrupt onset of severe limb pain, paresthesias or sensation changes, pulselessness, coolness to touch, and paralysis. The diagnosis is based on clinical presentation and confirmed with an ankle brachial index, or ABI, which is a measure of the ratio of the systolic blood pressure of the arm and the ankle. Patients who have normal ABI but high suspicion for PAD may undergo exercise testing. Additional imaging, such as with duplex ultrasonography, CT or MR angiography, or catheter angiography, may also be used to confirm the diagnosis. Management focuses on prevention of coronary artery disease, as patients with peripheral artery disease have significant atherosclerosis with a 20% 5-year non-fatal risk of MI or stroke and a 30% 5-year risk of fatal MI or stroke. Patients should have complete smoking cessation. Medications include high-intensity statin, single antiplatelet agent with aspirin or clopidogrel, tight blood sugar control, and tight blood pressure control with ACE inhibitor or ARB. A regular exercise program of 30 to 45 minutes 3 times a week reduces symptoms. Silastazole can be added for symptomatic improvement, but is contraindicated in patients with heart failure. Low-dose rivaroxaban can be used in combination with single antiplatelet agents in patients who have undergone revascularization. Revascularization is reserved for patients with chronic symptomatic PAD and chronic limb-threatening ischemia. Emergency revascularization is for patients with acute limb ischemia. Complications of PAD include Leriche syndrome, which is aortoiliac occlusion, which causes claudication of the bilateral buttocks, hips, and thighs, and erectile dysfunction, and limb loss resulting from tissue gangrene and amputation. The prognosis is poor. 10 to 20% of patients progress to worsening symptoms. 1 to 2% of patients develop chronic limb-threatening ischemia. Revascularization can help. The most common cause of death is from MI or stroke. Let's talk about the macrovascular complications of diabetes. Diabetes is a disease of dysfunctional glucose utilization that damages many organs through the blood vessels. Macrovascular or large artery complications of diabetes include coronary artery disease, cerebral vascular disease, or brain vessel disease, and peripheral artery disease. These complications are driven by accelerated atherosclerosis, plaque formation, and vascular occlusion, as well as comorbid hypertension, dyslipidemia, and obesity. The pathophysiology is that chronic hyperglycemia or long-term high blood sugar drives chronic metabolic inflammation or irregular immune system activation. This is compounded by independent risk factors such as high blood pressure, high cholesterol, and obesity, which is found in many diabetic patients. This inflammation can manifest as oxidative stress and smooth muscle effects, which damage artery walls. Risk factors of developing microvascular complications of diabetes include the duration and the severity of hyperglycemia. Type 1 diabetics are more likely to have complications. Ethnicity or income level may have higher incidence of diabetes because of health disparities. Prevention of diabetes-related complications is achieved through regular screening, control of hyperglycemia through measuring of hemoglobin A1C, lifestyle modifications, pharmacotherapy, and treating comorbid conditions. Routine screening for diabetes complications should be initiated at the time of diagnosis. The target A1C and anti-hyperglycemic medication is tailored toward the patient's risk factors and comorbidities. Targets include less than 7 for most patients or between 7 and 8 for elderly patients with multiple comorbidities. Lifestyle modifications include dietary changes such as increased fiber, more fruits and vegetables, less processed foods, and exercise of 150 minutes per week of cardio and 2 to 3 days per week of resistance training, adequate sleep, and mental health hygiene. Blood pressure goal is less than 140/90 for most patients, and stricter control of less than 130/80 may be appropriate for some patients. Statins should be taken by most patients with diabetes who are over 40 years old. Aspirin can be considered for patients with known coronary artery disease. Patients with obesity should aim to lose 5 to 10% of body weight. They may be assisted with lifestyle modifications or bariatric surgery. Pharmacological options are many and are selected based on patient-centered decision-making. Patients with diabetes are at an increased risk of silent MI due to autonomic dysfunction or dysfunction of the nerves. Stroke and peripheral artery disease are more common in patients with diabetes. To prevent complications, patients should seek regular assessment of cardiovascular risk factors and screening for peripheral artery disease in patients older than 50 with foot complications or smoking. Directed pharmacotherapy include metformin, glycoprotein-1 receptor agonists like tirzepatide and semaglutide, and sodium glucose cotransporter 2 inhibitors such as empagliflozin or dapagliflozin. Today, we reviewed coronary artery disease, complications of coronary artery disease, including peripheral artery disease and myocardial infarction or acute coronary syndrome, discussed comorbid diabetes, Prinzmetal angina, and the complications of heart catheterization. If you would like more information or you want to book an appointment, go to www.healthnetp.com.